We're going to talk about beyond injury, how high performance therapy builds stronger, more durable athletes. We're going to wait a few more minutes. We have a couple extra that are still waiting to sign on, so just give it a few and then we'll get rolling. Wait about 2 minutes and then we'll get rolling with it. Give it about another minute and we'll get rolling. All right, let's jump into this. So, two quick housekeeping details for us. Over here on the right hand side of your screen, there is a chat bot. So, any questions that come up, if you want to ask the questions, you can ask those questions here. And I will send that in there. So you see that pop up over on the chat side. And then also you'll see handouts. There is the 360 performance profiling. So I just remind folks to download that at the start of it so you don't forget about it. We're going to talk about that as we get through the webinar, but just wanted to call that out so you didn't forget to download it and you had it as a free resource for joining us here today. So let's jump into this webinar here and let's get through how performance therapy is going to help us build stronger, more durable athletes, right? Today's objectives, what are the common disconnects between rehab and performance, right? How do we bridge that gap, as folks like to say, and how do we limit that disconnect that often happens? We're going to talk about how training does not equal rehab. Now, that's been a fantastic phrase that's lived in our industry of performance, training, therapy, rehab equals or training equals rehab. And we're going to talk about how training is a part of the rehab process, but rehab is not a part of the training process. And also, I don't know if you just heard that bird, but my home is going through some repairs right now. So I had to move my out of my home office today. So if you hear some birds chirping or potentially an airplane going overhead, that's what you're hearing. The third thing we're going to get through today is what is the 3P framework of performance therapy? This is my exclusive framework that I've created that's given me success over 15 years in pro sports. And I'm going to share that with you today, give you some insights into a preview of what that looks like. We're also going to utilize some real world case studies and practical strategies that you can start using today because I believe we're all here to learn. And also, I would hope that when I attended the webinar, I wanted to walk away with something pragmatic that I could take away and utilize with my clients the very next day or the very same day. And at the very end, we'll have opportunity for Q&A. Again, you can use the chat throughout if there's questions that you have, but we'll also reserve time at the end for a live Q&A. Okay, just as important as this to talk about what we are going to talk about, it's also what this isn't going to be. So it's not a one size fits all injury guide or a rehab guide or a surgical protocol, right? That's not what this is about. This is giving you the tools, the resources, the frameworks to help you make effective decisions, to help you build athletes back up following an injury even better than they were before. This isn't going to be a deep dive into medical diagnoses. We will talk a little bit about pathogenesis, one of the cases, but again, we're not going to break down a bunch of injuries and get into the weeds on the medical side of things because not everybody here operates in the medical space. And then also on the flip side of that, this isn't going to be another sports performance talk where we talk about periodization, programming, which exercises are best for what. We'll talk about exercise selection. We'll talk about periodization, but not in the scope of that's all we're talking about. How do those components tie into everything else? So some realistic expectation that you can have by the end of this is you're going to have a clear framework for performance therapy. You can have some actionable strategies for both rehab and training. And ultimately, you have some practicality, not just theory. So briefly, who am I? If you haven't had a chance to meet me in person or catch me in any of the previous talks or seminars, my name is Adam Loiacono. That's how you pronounce my last name. Sometimes a tongue twister. By formal education and training, doctor of physical therapy, went on to get my board certified sports clinical specialist here in the United States for PTs, and then dual credentialed from two different organizations on the performance side, CSCS and PES. So with that, just giving myself the tools and the resources to be able to manage the whole continuum from performance, from rehab, from medical, and really help these athletes and clients, achieve their goals. So if you ever listen to one of my podcast episodes, Finding Small Wins, I always ask my guests, "Hey, what's your origin story?" But no one ever really asked me. You don't think to ask the host. So I felt it's important to just give breath to this briefly because it. I believe in context, and I believe understanding where people came from helps understand where they're at right now. So we go along this journey here. On the left hand side of this diagram, most of my career was spent in the soccer space. I was a soccer player. I was a college soccer coach, a youth soccer coach, transitioned into sports science and fitness coach at the pro ranks in the MLS, NWSL. And then ultimately, once I finished PT school, transitioned over to the medical side and really focus on the training room and the treatment and the therapy and the rehab and the return to play and weaving all those components together to ultimately land in the spot now where from the table, from initial injury, all the way through having a conversation with the coach and everything in between, really being able to integrate all that through all these experiences. I'm very, very fortunate to have had the opportunities to work in the spaces. So let's talk about this disconnect that a lot of folks refer to as silos or this gap between rehab and performance. So usually there's different goals when we talk about rehab and performance. So in performance, you're really not worried about constraints. You're really not worried about symptoms, injuries, things that potentially could be worse if you go through with a certain exercise or certain type of programming. On the rehab side, our constraints are high. We have symptoms, we have limitations. So already the goals and intent are just different, right? Rehab focuses on restoring function. Performance is going to focus on enhancing abilities. Not saying rehab doesn't focus on enhancing abilities, that becomes part of it at the end, but ultimately they're just different starting points. Then within rehab, within performance, there are varying methodologies. And I always like to call out not only just varying methodologies of, hey, what type of periodization model do you like to run? Are you microdosing? Are you block periodization? Are you linear periodization? What school of thought do you subscribe to? Are you more of, Bosch and motor learning, or do you subscribe to maybe the Russian, Eastern Europe and the Soviets, or are you more, an American base where you got to push, pull, hinge, and knee dominant exercise, right? So there's all these different methodologies. And then also you layer in countries and cultures, right? Having the opportunity to work in a pro soccer locker room, you see all these cultural influences, and nothing highlights that more than seeing all the players come into the weight room and you write the lift on the board and you have some players from this country saying, yep, I'm not going to do that. I'm going to do this instead. And so there's just all these different elements to it that ultimately lends itself to have some of this disconnect. So what are the consequences when we have this gap, when we have this disconnect? Well, potentially suboptimal recovery from injury and or competition, delayed return to play, increased risk of re-injury, and potentially just poor communication because we may not understand what the other one's doing. We may not be able to speak the same language metaphorically or literally. So ultimately, if we can eliminate this disconnect and quote unquote bridge this gap, as you've heard a lot of not professionals, a lot of experts say, then we can ultimately bring these two together to create a more robust plan of care for any injury. And that gets us starting thinking beyond just, rehabbing that injury. So I like to refer to this diagram that I like to dub the continuum of, of return to play. And on the far left side is health, and on the far right side is sport. And then you have these different stops along the way, each with a very specific goal, which we're going to get into here shortly. But I like to bring this up because, as you'll see in the definition of what rehab is on the next slide, you can see that training and performance and sport, they're all a part of the rehab process. And growing up through elementary school, I was always taught by my English teachers, right? If the word is in the definition, it can't be a synonym, right? So when we think about what the actual definition of rehab is, when you just plug it into Google, it's defined as the action of restoring someone to health of normal life through training and therapy after imprisonment, addiction, illness, or injury. Now, most of us probably aren't going to touch the first two, imprisonment and addiction. Maybe subtly there is addiction to people working out. Like I've had a few, I've had a few of those where they just have to move, they have to do something. Like taking a day off is out of the question. But most of the time we're dealing with illness, and also injury is primarily the one we're dealing with. So it's just important to highlight that training and therapy are a part of the rehab process, but we have to respect at what phase that those become part of the rehab process. So I love analogies. I think analogies are very powerful. And what we're going to use this analogy to describe each phase of the continuum here is I want you to think about a Formula One racer. I don't follow F1. I know it's a big popular sport internationally. It's starting to grow here in the United States. But the name Max Verstappen, I think I'm pronouncing his name correctly. One that's won a lot of competition. You see his name pop up. So let's just use Max for example. He gets in a car crash. Well, the very first thing the crew's going to do is they're going to put out the fires, right? Someone gets injured, we want to make sure they're safe. We want to put out those fires. And in doing so, we're trying to just restore homeostasis. We're trying to, put out those fires, make sure everybody's safe, and kind of bring everybody back down to planet Earth after a crisis like that. So restoring homeostasis in, any type of injury, you're talking about your three big things of mitigating pain, improving range of motion, and if there was any sort of acute swelling or bruising or excess fluid in the area, right? We're trying to eliminate that as well. So those are kind of the big three things that typically influence the inability or ability to get back to homeostasis. So then the next phase of this is therapy, where we fix the broken parts. So right, Mac got in a car crash. Front axle's broken, spoiler's broken, part of the engine needs to be repaired. So this is where you get your mechanic, you go in individually, you fine tune each one of those parts. This is where maybe your athletic trainer, your surgeon has to go in and repair something, or your physical therapist, your chiropractor, they go into a very specific joint, a very specific tissue, and you start fixing that broken part through manual therapy, through modalities, through low threshold activities, right? So some of those exercises, if you're on the performance space, are your single joint exercises typically, or your low threshold, low intensity. We're just starting to build capacity and tolerate stress within that tissue. So this is what we refer to as like part task strategies, right? Tapping into our motor learning background. Next phase is training. So this is where, okay, the mechanics have fixed the car, that the axles are on, tires are on, spoilers fixed, engine's running great. Max is going to take that F1 car out on the racetrack and just go for a test run. No goals, nothing looking to achieve here. Just go get a feel for the track again. Make sure everything's working. The steering wheel is turning left and right appropriately. The wheels are in line. Aerodynamics are working fantastic. Gas pedal, brake, they're all working great. Same thing with the athlete that's coming back from rehab, coming back into training phase. Some might call this return to training. And so we start implementing whole task strategy or whole body movements. If you're in the strength and conditioning space, this might be your GPP, your general physical preparation. So I love this phase. This is my favorite one because you really are, it's problem solving. You're getting creative with what you do, right? No, in my opinion, not in my opinion, my experience, I'm constantly creating new exercises, not just because like it's fun, but because there's always subtle differences when someone's coming through the rehab phase where they're going to feel symptoms or something feels off. And so you just got to change the look of something. Maybe you got to use a kettlebell instead of a dumbbell, or maybe you got to use a medicine ball that's soft versus a medicine ball that's hard, or you got to do front foot elevated or heel elevated for a lower body exercise. Whatever it is, you create all these modifications so they can explore movement again. So in a vertical vector, we're talking about jumping. In a lateral vector, we're talking about change of direction. In a linear vector, we're typically talking about acceleration and sprinting, right? So how can you start exposing in the training phase so the person gets comfortable, just like Max takes his car out on the track and he's just getting comfortable being behind the wheel again, and the car is where it needs to be. We get into the performance phase. This is the fun stuff, right? This is where we can stop thinking about pain, stop thinking about symptoms, really just trying to push the upper limits of human performance here, try and get back to some of our pre-injury baseline data, right? Max is out on the track. He's trying to go for his fastest lap, or perhaps he's maybe trying to work on how tight of the corners he can turn. So he's just working on certain bends in the track, right? So here we're going to isolate out particular variables. So if you think, going back to the example of running, jump, change direction, linear, vertical, lateral vectors, we'll now say, okay, well, what's the KPI I want to measure for linear? Let's tease that out. Let's go a 30-meter sprint, and let's make sure we evaluate max velocity. Great. Now we're going to get on the force plates and we're going to do a counter movement jump, and we're going to evaluate reactive strength index. Okay, great. So we're just chasing all these single outputs to make sure that in isolation, like a science experiment, the athlete can tolerate those stressors of that magnitude. Now, once we layer in fatigue and capacity, that changes. But in my opinion, we have to make sure that they can tolerate the maximal efforts in a ready state before even trying to layer in anything on fatigue side. So I love this phase also of, let's see how far we can push you and get you back to baseline. And then ultimately, sport, activity, doesn't have to be sport here. It can be activity, it can be competition, right? Let's take that car, get out there in Monaco, beautiful views, beautiful people, beautiful environment, and go for a race, right? Sport is organized chaos, right? You can't control everything. It's very difficult. No two games are ever the same. No two plays are ever the same. So this is where we just make sure we gradually expose them back to sport. And we'll briefly touch upon this at the end of the webinar. But that's really how this continuum is in each one of these phases. So, to highlight one more time about what training is and how we can incorporate that within the rehab process, whether you are a medical provider or you're a um, performance provider or you're a little bit of both, right? Training is necessary to improve athletic qualities, right? We have to get off the table if you're a physical therapist or athletic trainer. Uh, you have to get moving. You have to get doing things with high intensity, high effort, right? Training is going to bring about a different energy and different focus. And this is where I think people, not people, I think we as an industry, this is where egos get in the way. And we feel that, I'm the person that's managing this rehab. Injury happened, training happened, treatment happened, rehab started happening. I'm not ready to pass the buck. And we kind of, get into the weight room as well, or we try doing more than maybe what's in our scope, right? Think about the continuum. Who's best equipped to manage each one of those phases? So it's important to highlight. Sometimes it's just about the energy someone can bring. I'm not the most motivating, energetic person, but one of the strength coaches I used to work with, super energetic, super motivated. There was just days where I was like, dude, I'm gonna punt this guy to you. Like I need some big energy here. He's like, I got you, bro. And so it's just recognizing that training also requires a different attitude, energy, and effort, not only from the athlete, but also from the provider as well. So think about that like as another way to how we can kind of break some of those silos, bridge that gap, and eliminate some of this disconnect. And also through training, as we progress through rehab, these constraints that we talked about earlier, they slowly diminish. So the solution to this disconnect kind of touched upon a few of them, but let's summarize them here. It's important that we understand the continuum and understanding where are you most effective at, personality wise, skill set wise, licensure wise, certification, like where are you most effective at if you're working in a team environment or if you're working with colleagues in a clinic, right? How can you impact that athlete along that continuum? If we implement the 3P framework, which we're going to get into here next shortly, right, what it's going to do is help us guide decision making, right? It's going to reduce egos and biases because it's going to, if we eliminate egos and biases through processes and through consistent efforts, it kind of doesn't really matter what the bias or what the egos are because we're all trying to move toward a certain goal. And so what it also is going to help us do is return to fundamentals and proven methods, right? There's so many continuing education courses out there. There's so many acronyms and certifications and tools and tricks and tech. And I subscribe to all of them. I mean, I love it. It's how we all learn and grow and push each other. And sometimes I think we get caught up in the marketing of it and or the social media aspect of it and trying to try something new. And in actuality, a lot of what we're doing boils down to some of the principles that we're going to talk about. So I just remind yourself that, okay, what am I really doing here when I do this particular intervention, right? If you can really pull back the science and pull back what the principles are, I think you'll see a lot of us are doing a lot of the same things. Ultimately, right, we need to create cohesion and goals, right? That's going to be the ultimate solution to this disconnect. If we have a common goal, the methodology, the philosophy, the personality, the ego, the bias, it really shouldn't matter as long as we're making progress towards that goal. And so by having these specific goals, it's going to help us eliminate the noise maybe around us. Okay, if you work in team sports, there's a lot of noise, a lot of pressure at times. So just being consistent with your process helps kind of minimize some of that. And ultimately, as long as we're making progress towards that goal, really the tool shouldn't matter, I hope. So let's talk about what the 3P model is: principles, process, plans. That's what the 3P stands for. So principles are foundational truth or belief that influence decisions, right? So I mentioned that earlier, getting back to fundamental truths, right? The process are consistent, repeatable steps that ensure progress over time. And then these plans are the detailed roadmap, similar to kind of the roadmap of the origin story of, moving towards a specific measurable goal. So let's dive a little bit deeper into each of these principles. Rooted in anatomy, physiology, biology, chemistry, physics, right? You think about, any sort of exercise program that we're going to write, it's going to manage physics, it's going to manage load, it's going to manage velocity, right? A lot of these things just tie back to physics. And then over time, it's okay, accumulating stress, right? We talk about chemistry when we're talking about respiration, when we're talking about breathing, right? Whatever strategy that is, right? A lot of this comes back to anatomy and physiology. So just reminding ourselves that when we think about certain things, what are you actually implementing? What are you actually intervening on? Okay, the process is bringing these principles to life. So it's like, how can we take these and act on them to be meaningful and help us guide our decisions with what we do? And what having a consistent process that's repeatable over time, it helps us minimize any sort of emotional influences, right? I've been guilty of it, right? There's pressure from within the organization, there's pressure from outside, there's pressure from the athlete or the player, right? They're like, I want to get back sooner, Adam. Hey, I want to get past this injury faster. It's like, okay, there's a little bit, emotional investment there, but you have to recognize, okay, let's just stick with our process. Let's trust time here and we'll get through this. And then plans, right? They have to be context dependent and they have to be adaptable, not rigid. And it's very important. It's a key component of, the 3P model and performance therapy, because if we're rigid in how we think and every ACL case gets this protocol and for this athlete, and or every ankle sprain I see just gets this plan, it's a good starting point. But ultimately, as we're going to break down some of these principles, right, we got to treat everybody as one, right? No two injuries are ever the same. No two clients are ever the same. No two athletes ever move the same way. There's certain buckets and bandwidths that we all probably operate in, but we have to recognize that we're dealing with complex humans, right? Humans are athletes, and humans and injuries are very complex. So just having the adaptability to manage all that is key here. So these are the 10 core principles of the 3P model. And the 3P model, again, principles, process, plans. The top three, I can guarantee, I'd be willing to bet many of us are operating within those top three. And then the next seven are lessons I've learned and things I've pulled from other industries, influential books that I've read. And these are just messages I've seen time and time again across different industries. And I believe if multiple industries are seeing the same thing or practicing the same thing similar, there's got to be merit to it. So let's break down coordinate. Let's break down the first three, and then we'll briefly touch upon the rest. So coordinate movement, right? That's the foundation of anything human performance. You can't perform a sport, you can't perform an activity unless you move. And so coordination of that movement, proficiency being how can you execute at the highest degree with the highest quality, efficiency being can you can you accomplish that movement with the least amount of energy? So both of those are closely related but subtly different. All right, so that's all about coordinating movement. And that's what a lot of what we're trying to do in the therapy space, in the weight room space, right? How can we improve quality of movement with a lot of the tools, tricks, cues that we have? Managing forces. Now, most of us think forces, we think strength, acceleration, speed, power, deceleration, right? Those are a lot of the things that are important. They're a bulk of what we do. But one thing that I think we often miss is the force of gravity. And how do we manage gravity just standing upright? And that's what a lot of physical therapists love to look at standing posture. And I've come to appreciate standing posture really gives us insight into prediction of ranges of motion or certain biases towards ranges of motion. So it's important that we also evaluate just standing posture and shapes that we see, because that's going to give us some biases or give us some indication of things we may or may want to include or may want to stay away from in therapy or training, right? Because they just may not be built for it, right? Then we want to talk about enhancing fitness. So fitness is, as I like to define it, how prepared are you to be able to fulfill a particular role? Notice I didn't say anything about VO2 max. I didn't say anything about any sort of fitness test or physical fitness test, because ultimately fitness is about, can you accomplish what you're being asked to do and do it over and over again. And the reason I say that, so you can think about technical skill, tactical skill, psychological readiness, emotional maturity, right? Think about a veteran player in the NBA, 36-year-old point guard versus, a 22-year-old point guard just coming out of college, right? 22-year-old point guard may be more physically fit, but probably doesn't have the same tactical acumen of the 36-year-old vet. Certainly doesn't have the emotional maturity or psychological maturity that 36-year-old vet has. And so does physical fitness define what fitness is? Not in sport. There's so much more to it. So ultimately what we are impacting, it tends to revolve around the physical side, but I would be remiss when we talk about a framework that if we don't include the other, we're really missing the boat on what that really is. Okay, the next seven, let's briefly to highlight these. So commit and learn. There's so much we want to do. There's so much we could do. Ultimately, you just got to commit to something, and then you learn from it. I made this mistake all the time. Like I'd be afraid to commit to something, or I'd commit to it, I change, piggyback, do it again, and it's like all of a sudden it's like I'm doing this big crazy big loop, and I don't really know what worked or didn't work at the end. So commit and then just learn from it. Okay, context matters, and so context matters is so important because there's so many things that are influencing the outcome of any rehab plan, and what you may do in one case may be different in the other because the context is different. Context can be a multitude of things, from accelerated recovery because there's competition coming up or a game coming up. There could be, if you're working in the team side of things, it could be, hey, is the contract influencing some of that context? So there's just so much that you have to consider, and understanding why any particular athlete or colleague or team may have an approach to a certain particular injury. So just remember that. N equals one. So kind of doubling down on context matters, but think it more about like to the actual person. And so, although you may have seen 50 ACLs or 50 ankle sprains in your career, there's always going to be subtle differences amongst them. Now, chances are 80% of the time you're going to rinse and repeat a lot of what you do, but recognize that everybody's their own individual case. And I faced this a few times in my career in team sports where the individual had more, emotional investment sometimes in the rehab plan, or there was more pressure from for whatever reason that ultimately kind of changed some of what I did. And like I wouldn't be able to repeat that. I would never been able to prepare for it. Just had to be adaptable with what I did. So just treating every case as its own. Prioritize and simplify. So there's so much that you can do. Right. And so, how do you decide what to commit and what to learn from? Well, you're just creating your priority list. And that's what the 360 profile is there for you to do. Right. If you have the opportunity to evaluate a lot of testing or evaluate a lot of different variables, it allows you to then prioritize what's most important, not only for an injury, but also for holistic health and the overall athletic ability of the individual beyond the injury. Right? Invest in preparation, not prediction. This comes from a lesson I learned early in my career around sports science. Right, I was, big part of my early role in working MLS was sports science and evaluating GPS data. And there was this push, right? We're all trying to predict when players would get injured. And I did make a mistake one time of recommending to one of my superiors, like, yeah, I don't think this player should play. I think he's going to get hurt this weekend. Pretty much is what I said indirectly. And we'll never know if that would have happened or not. We were looking at data, we're looking at trend lines, and we had a strong inclination of it. But ultimately, like that's such a hard thing to do. And when you work with data for a long time, you realize you need massive amounts of it to even get close to prediction. Now, I think with the likes of AI and machine learning, perhaps that's getting better. But I'd rather invest in having my contingency plans to be able to manage certain situations than trying to predict what's going to happen next. I'd rather be prepared and be adaptable. Treat the person, not the diagnosis. So it's important that, yeah, we manage what the injury was, but we can't neglect everything else, right? There's still a human body. There's still a left arm if a right leg. There's still a left left side of the body if the right side was injured. There's still a heart. There's still some lungs, right? We still got to train all of that as well. So treat the person, not the diagnosis. And ultimately, consistency is king, right? That's why these frameworks are here. That's why we talk about 3P. Consistency is king from everything that we do, but also tech and data is just rooted into what we do nowadays. And so it's important that our any sort of testing protocols or data collection or how we're measuring certain things, that we're consistent with that too, because that's going to drastically influence the results of any sort of analysis you may do. Two words I want you to remember from the second P and 3P, that being the process, is experiment and exposure. So experiment is this idea that we never really know what's going to work. We have strong inclinations, right? But when you start doing this for years on end, you think you're gonna do an intervention, and then it doesn't work, and then you try something totally different, and all of a sudden it works, and you're there scratching your head like, what the, how and why did that work, right? So ultimately, we are experimenting, and what I want to highlight here is this concept of safe to fail experiments. And what I mean by that is a lot of us do this inherently. I'm just putting a name to it, right? You're in that training phase. You don't necessarily know what exercise is going to um, be safe for this person to participate in or not provoke the most symptoms, right? Like think about someone that just has like a chronic hip impingement. They're probably going to do really well with front loaded squatting on heels elevated because it's going to allow them to shift their weight back and decrease the degree of hip flexion that happens. Probably going to feel pretty good, right? If you didn't know they had hip impingement, you might have to experiment and say, okay, I don't know which variation of squat's going to work here. So let me just try a few different ones with light load and just see which one feels better. And then what you'll do is you'll amplify the one that eliminated the eliminated those symptoms, and you'll dampen the ones that provoke symptoms. So that's this concept of safe to fail, amplify, and dampen. And that comes down to also like on the treatment table. So you may have something in your wheelhouse, a particular strategy of manual therapy or how you like to approach uh, treatments on the table. Ultimately, you may not know what's going to work until you start trying a few different interventions and testing and retesting, right? And so that's what's these known unknowns, measuring your known unknowns. That's an expression pulled from the Cynefin framework, Cynefin. Cynefin framework is a sense-making model for decision making. I encourage you to just Google that on YouTube. There's a couple of short, 5-6 minute videos there. You can learn more about it. And so when you think about understanding your known unknowns, right, you don't necessarily know what the result will be. You don't necessarily know how much that will be. So you measure these variables to then turn those unknowns into known variables. So it's a maybe a convoluted way of saying have your KPIs and make sure you're measuring them. And so I encourage you to just explore the Kinevin framework and might get you thinking a little bit deeper on that. Exposure, I'm going to jump down to the third point here. And this is one of those words that I routinely see across multiple industries. Periodization models and strength and conditioning. Someone wants to lose weight or put on mass. Well, you slowly expose them to a surplus or a restriction of calories. Psychology, we have veterans that are coming back from war. They've got stressors that trigger certain emotional or physical behaviors. And so one thing, one uh, methodology in the world of psychology is known as exposure therapy. I'm going to gradually expose you to the very stressor stimulus that provokes your symptoms, so that eventually over time I desensitize it to you, right? So desensitization is something that a lot of us do when someone's in pain or having symptoms. We just slowly expose them to that movement until over time they develop the stress tolerance to endure that. So exposure is also acute chronic principles. It's also quote unquote load management that you hear a lot about talked about, particularly MBA. And the final thing I want to leave you here with, exposure is this is a book quote, one of my favorite quotes from a book called Great by Choice. And it's called slow, it's slow when you can, fast when you must. And this was in reference to, looking at certain companies, how did they 10x their revenue? How did they 10x their profits? How do they 10x their value? And one common theme was they go slow when they can and only go fast when they must. And so in our context, most of the time we probably should take it slow during the rehab process, during injuries, during training, because over time they're going to gradually just build up and just stack those days. We can certainly go fast, right? You can certainly cut weight for an event in 2 weeks. You can certainly expedite a rehab or training process, right? But the analogy I would use here is like just imagine you're going up a steep hill versus a gradual hill. If both people take a small step backwards, the person that's stepping backwards on the steeper incline is going to have a larger setback versus the person that steps back on the gradual incline is going to have a smaller step back. So just reminding ourselves here, yeah, I'm sure we could all accelerate a lot of what we do. But over time, I've learned just like fine wine, good things take time. And so just recognizing that we have to be patient and just do our due diligence and trust the process. Okay, and ultimately, we just land on the final P, which is our plans. Constraints, monitor and manage, adapt and adjust. So constraints, individual task environment, right? This pulls out of dynamic systems theory. Monitor and manage, again, amplify desirable adaptations, dampen the undesirables. And then adapt and adjust. You heard me say the word adaptable numerous times. It's just important you leverage the feedback you're getting from your client, your athlete, or even any sort of tech or data that you may have as well. So let's just jump into some, practicality. Now we spent, the first half of this webinar breaking down some theory to kind of lay the groundwork for what we're here talking about here. But it's important we, leave you with some practical tools as well. So what we're looking at here is a frontward view of, the lower extremities of a soccer player. And I just want you to start tongue twisted there. Start to observe the shapes that you see around the quadricep and around the knee. And just notice how you see certain shadows on one part of the leg, but you don't see them on another. You see them on the right, but you don't see them on the left. You see a kneecap pointing to the left. You see a kneecap pointing to the right. And so reminding ourselves that as we look at posture, it gives us insight into resting tone. It gives us insight into joint ranges of motion. And so love looking at posture as an entry point into performance therapy. And so this particular client, history of patellar tendinopathy, difficult time accelerating. They have, and then, excuse me, they want to break down the considered pathogenesis of, this chronic posture. And so what I mean by the pathogenesis in chronic posture is, without getting too much in the weeds here, at the tail end of a degenerative tendinopathy, there's a process known as angiogenesis, where the body's trying to bring blood flow into that tissue. And if we think about chronic posture, muscles stay tight for a long time. Is that going to compress certain blood vessels to the area? So this is just theory, right? I'm just spitballing with you here. So I think about to myself, well, how can I improve range of motion to potentially improve blood flow to a particular area? So in this particular photo here, We have on the left-hand side what looks like a more hypertonic, a more tensed vastus lateralis. That's that lateral quad. On the right side here, same thing, but more so over the vastus medialis. And just look at the shadows that are underneath that. All right, so a little bit more bulk over the vastus lateralis, a little bit more bulk over the vastus medialis. And then what you pay you pay attention to the kneecap. Well, the left side is rotating out, on the right side is kind of pointing forward. So now we're starting to create this bias of, just by looking at posture and appreciating muscle tone, what do I expect to see from hip ranges of motion? All right, so let's go see what that looks like. So we have here, the ranges of motion from their assessment. Feel free to take a screenshot of this, totally cool. And just notice the asymmetrical twists and turns that exist in the shoulders and that exist in the hips and the knees. And so it's just a recurring theme. So based on some of the shapes that we saw, we would expect to see some sort of asymmetrical ranges of motion based on muscle shape, right? You got to remember, muscles are areas of tension, high areas of tension, low areas of tension. And so they're going to influence certain bone positions, certain joint positions, and limit certain ranges of motion in certain vectors. The second thing that we can look at here is that they had their shoe on. Excuse me, they had their shoe on, so we weren't able to see their foot. But I can tell you that they had a pes cavus foot, so they had the high arch, and they had the claw toes. And so from looking at a postural photo, what I've seen over time is when typically see a pes cavus foot, okay, you see their center of mass is shifted forward, right? So their center of mass is shifted more over their metatarsal head, not necessarily the midfoot or rear foot. And so with that, okay, you start to get this pes cavus foot. With a pes cavus foot is a high arch, and the foot kind of represents this ER position, this externally rotated position, or supinated foot. So now we have this pes cavus foot and claw toe. So what do I expect to see up the chain, right? Maybe supinated foot, probably tibial ER, probably a rear foot that is in valgus or inversion, right? You see potentially limited dorsiflexion because of the arthrokinematics of the ankle. If it's externally rotated or supinated, it's going to be very difficult to get some dorsiflexion. So just by looking at shapes, looking at posture, we can start to make these hypotheses on ranges of motion. Now, if you can't put your hands on someone to get table tests, well, you can start to think about these things and talk to someone that is able to get their hands on them to help you understand them a little bit better. And then the final thing we're talking about here is this compression strategy. Like most female soccer players have this compression strategy, right? Narrow front to back and left to right side. So anterior, posterior, medial, lateral. They're just kind of compressed. Like think about like a toothpaste. You're just squeezing the toothpaste out of it. And so what that's representative, as you may have heard, if you haven't heard, or if you have heard, infrasternal angle, ISA. Someone that's a compressed individual, someone narrow torso, you're going to see this narrow infrasternal angle. And all this is representing is what type of movement capabilities do they have. The shape of their torso, the shape of their pelvis tends to lend us to more movement strategies than the other. And so with this, we saw a narrow torso, compression within the rib cage, and then the straight leg raise limited to 40 degrees gives me indication that the pelvic outlet is also compressed. So now I just have this compressed individual that also has this asymmetrical twist and turn through it that's dealing with a chronic tendinopathy, right? So all this compression that gets me thinking, okay, maybe they just need to release some of this tension, release some of this compression, utilize some asymmetrical activities to get them to twist and turn in the opposite direction. So what does that look like? So this is one of my favorite things to do with this particular athlete. And what this is that there's a lot of black and grays here, but I'm holding onto a cable in my hand and it's in a low position. So I'm starting in low and I'm finishing high, or commonly known as like a cable lift. Now, cable lifts traditionally are viewed as anti-rotation exercises or rotation exercises, but I encourage you to think about what's really going on at the complexity all the way from the foot all the way up to the shoulder. So that right leg, when I'm going from low to high, that's the same mechanics that are going out of a cut. So when I do a cable lift, I'm getting out of a cut. When I do a cable chop, I'm getting into a cut. And so now I'm leveraging hip mechanics there. And so this is where, when I see such an asymmetry in some of the table tests, and then it's represented within muscle tone, I feel comfortable doing asymmetrical lifts or doing a lot of unilateral activities, because what I'm trying to do is restore some of that joint position through exercise, not just manual therapy. And a big part of being able to do that is giving them the right cues and the right activities. And so what the cue here was, as you can see, my right foot is elongated. So it's in this abducted, externally rotated position. My left leg is more, I wish it would be in a better, adducted position. It's not the best adduction, but because I'm pushing over my left side, I inherently have to get into more hip flexion and IR, which she was lacking on that left side. So by just cueing this up of pushing through your right foot, find your left heel, get your center of mass over that left foot, we're getting this left hand turn back into the pelvis, getting their weight back over their heel to be able to recruit some hamstrings and pull that pelvis backwards. And so by utilizing some of these activities, was a way for us to restore some of that range of motion. Other things we did were crossover sled drags. Again, great way to pick up IR and ER in the hip as long as you maintain full foot contact, right? Pushing through the arch, pushing through the heel, and then also unilateral pushing and pulling, right? They had an asymmetrical torso. Didn't feel as comfortable putting bilateral lifts on an asymmetrical foundation. So it's very important that we talk about foot contacts, especially in that last exercise that you saw, because when you talk about foot contacts, we're talking about sensory input. And certain aspects of the foot are going to drive certain motor behavior up the chain. So, and if you wanted to, you could stand up right now and you could just close your eyes and standing. And all I want you to do is, shift more of your weight towards your toes and then shift more of your weight towards your heels. And just notice what muscles are firing as you shift your center of mass at different parts of your foot. And so when you have an appreciation for that, hey, if you're telling, if you give the external cue, hey, make sure you're pushing through your heel or pushing through your arch, right? It's going to fire certain muscles up and down the chain and promote the behavior that you may want. Rather than saying, the classic example, oh, make sure you're squeezing your butt, or you feel your groin firing. And sometimes it's hard for people to feel that. They don't have great awareness. So by giving them the right cues through foot contacts, we can manipulate the sensory input to ultimately alter the motor output. And so by doing these things, you can really improve range of motion without manual therapy. Another example here, right? This individual, he's a cool dude. He rocks some great shoes, right? Always rocking some Sambas or some kind of Adidas shoe. But I'm going to call your eyes to the right shoe and the bottom right corner of it, of the brown aspect of it. And just notice the wear on the right shoe versus the left shoe and how there's more wear on the outer portion of the right heel in comparison to the left. So let's start to hypothesize, like, why is that? Well, if they're putting more pressure and more stress through that limb, then chances are they're more lateralized on that side. They're bearing more of their load, their center of mass on that right leg. If they're also putting more weight through the outside part of the foot, chances are they're in a more relative supinated foot. That probably have some tibial ER. That means probably other sides maybe a little bit more pronated. Maybe you look at their arches, we have an asymmetrical arch. So you just start to think about these things just by looking at shoes. And when we flip them around, we look at the front side, you can see the tongue. The tongue tells a pretty good story too. So look at the right tongue of the shoe versus the left tongue of the shoe. Now all of a sudden we see, okay, wow, why is there an asymmetry there too? Well, if we're riding so much on the outside of our foot, well, we constantly are externally rotating, supinating, the tongue's going to follow that too. So just little tips and tricks you pick up along the way. You can start just looking at feet and notice, okay, where's the wear on some of the shoes? Where's the tongue position relative to standing? So that just all tells a story. Now, a little bit of history on this particular client. He's going through multiple knee surgeries. This was in between his first and second knee surgery. So yes, there's some atrophy there. There's some arthrogenic inhibition on that left limb. So the definition of that vastus lateralis on the right, don't really see much of it on the left. In this particular photo, he was dealing with a little bit of swelling that day, which is difficult for him to recruit that quadricep. But I want to just give you a little bit of background information too, that he was constantly reporting this like medial knee pain and always just felt like he couldn't fire his glute, as he liked to say. I couldn't feel my hip. Well, that kind of falls in line with what I've seen, where someone lacks the internal rotation abilities of both the hip and the knee. And so what we were able to figure out through all this was, his left leg was kind of sitting in external rotation. Right. So he had his like chronic externally rotated left femur. Well, naturally, that's going to make it very difficult to recruit a vastus medialis. So oblique to VMO, it's going to, when you get into deeper knee flexion moments, it's going to create that medial pinch, because if you recall from the screw home mechanism and the unlocking of the knee, when we flex the knee, we need a little bit of tibial IR on the femur. And if you're sitting constantly in external rotation, you eventually, when you get to a certain degree of knee flexion, you get a little bit of pinch within the joint. So now this was for him. We were trying to go through just the return to training phase for him, right? That's what we think about the continuum, return to training. And so unfortunately, for the sake of this photo, we had to disconnect from the TV, but he's on the force plates because we were using biofeedback on the TV to let him know how much pressure he was putting versus right versus left, right? The ability to bear weight equally through left and right. And right away, right here, you see he's got this right shift. You see the right leg. It's almost like he's avoiding that left side, which coming off of surgery, very normal, very natural, but also, okay, it's still something we have to correct here. And so, one thing you're going to hear me say is an orthotic is not just what we put in our shoe. We often think of orthotics as this insert that goes into our shoe, but I like to define an orthotic as any sort of object or apparatus or tool that's going to manipulate sensory input to alter motor output, right? That's what your foot orthotics are doing. They're changing the sensory input at your feet to improve overall mechanics of you when you're walking or running. Same things are true if you wanted to do a Zercher squat, put a barbell on the front side versus a barbell on the back side. That's going to change how you fire, how you utilize certain muscles. You do heels elevated versus non-heel elevated. You put a soccer ball between someone's knees. You do plate reach versus goblet squat, right? All these things, you're just trying to manipulate sensory input to get the motor behavior that you want. So that's all we were doing here. Threw a soccer ball between his knees to help him cue up some better pelvis position. We added the plates there because he was having a tough time staying out of the front of his knee. His weight, his center of mass kept going forward, so he was getting like anterior knee pain. And what you can't see here is he's also holding a plate, a 10-pound plate, like a little reach. So if you look up here at me, he's just like reaching in front of him. We tried a goblet squat, right? Experiment, safe to fail experiment. Tried a goblet squat, didn't get the motor behavior that I wanted. So I switched to a plate reach, and that cleared it up really quick. So again, safe to fail experiments, find trial and error, figure out what works, and then eventually stick with it. So to highlight the 3P framework in action, right? We evaluated some posture, we evaluated some movement. We talked about how joint by joint can support as like almost checks and balances of some of those biases we start to see when they're walking or they're standing, just managing the forces of gravity. We leverage the 360 profile. Again, it's there for download for you, and this is where you can prioritize and simplify and commit to what it is that you want to focus on with a particular athlete or client. Then you go through some experimentation phase to figure out what's working, what's not working, what's going to be the best exercises for them, what's going to be the best therapies for them. And then you just got to gradually expose them to those stressors over time. Expose them to more fitness, expose them to more forces, expose them to more intensities, volumes, density of exercises, right? Just gradually build up that stress tolerance. You got to monitor and manage, right? So we were monitoring, managing range of motion with a soccer player and monitoring and managing the overall weight shift through force plates with the other individual. And then we chose to amplify the variables, the exercises that were giving us the positive adaptations that we wanted by monitoring. And then ultimately we dampen the activities that weren't. And so then we have to get back to return to sport at some point or return to activity. So let's jump over there. And so what we can utilize this 360 performance profiling is as part of that return to sport, return to play criteria, we can leverage a lot of these variables. Now, there's just a quick snapshot of it. There's multiple pages in the document. And all we look at every single, you can break it down to parts, you can break it down to the whole system, certain movements. And when you think about prioritize and simplify, if you have the opportunity to go through a lot of these tests, well, if they're passing a certain, quote unquote, passing a certain test based on these metrics, then we know that's not a priority for us. But if they're significantly low in any one of these variables, then what we want to do is make that a priority for us. Or if it's relevant to the particular injury, that becomes a priority for us. So if you've never worked on the team side and never had an opportunity to learn from some of the coaches, here's a simple tool that we can use to understand how we can progress return to participation, return to play. And two key variables that we can manipulate are distance and size of the space that they're playing in, and the number of players in that space. And so this is a diagram that I learned when I was coaching youth soccer. Through the French Football Federation. And this was a cool diagram that I always love, and I always love to share it because it's so simple in it, right? So the smaller the space with a smaller amount of numbers is going to be more acceleration and strength based. And now if we go to the top right-hand corner, the large space with larger numbers, traditional 11v11 in soccer, it's going to work on more endurance, more aerobic. You're going to have more exposure to higher velocities, right? And then the kind of the gray space in between, as you manipulate certain variables, you're progressing to a little bit more speed and progressing to a little bit more speed endurance as well. And so just by navigating size and number of players, we can provide our recommendations to coaches, high school coaches, high school athletic trainers, people that are outside your direct care and say, yeah, okay, I'm working on my strength block right now during this rehab phase. I think it's important that we just stick to small spaces and low numbers. If you're in basketball, maybe that's one or two dribbles, light contact. If you're in soccer, maybe that's just technical work, a couple dribbles here and there. And then as you start to work on maybe more speed and maybe more endurance within the return to play, then you provide the same recommendations to the coaches. Okay, yeah, let's expand the space a little bit. Let's open it up. Let's let them expose themselves to running at higher velocities and just overall total distance to increase the volume, increase the endurance. So this is a simple tool that we can all utilize to help provide some context to some of those conversations. And just a few quick tips as well from my time of being a youth soccer coach and a college soccer coach. You can also have conversations with a coach around number of touches or passes or point systems, right? Because those are all going to manipulate the intensity or the quality of the activities. So, for example, in soccer, if you played, one touch passing or two touch passing, that required a lot more movement from everybody to find open space because as soon as your teammate received the ball, he only had another touch to get rid of it. Or in basketball, you have a point system. If you want them, if you want to increase the amount of high speed running, what you can do is, in order for the team to score, every player has to be across half, and so now you're just increasing transition offense, and so now you're increasing higher velocities, more distance. So just by implementing some of these rules, you can manipulate the quality of physical output that the athletes are participating in. So we're almost there, y'all. I appreciate you taking time this Wednesday evening and joining us. So 4 quick bullet points to bring us home, right? Thinking in systems, right? I hope I highlighted that. Yes, we're focused on an injury. Yes, we're focused on a diagnosis. But in order to think beyond just the injury, we have to think in systems. How is this part of the body connected to that part of the body? What am I seeing here that may be influencing that injury? Right, we have to have goal-oriented planning, and that's what you can utilize the 360 performance profile for, right? Pick your specific goal, work towards that. Once you hit that goal, find a new one, keep progressing. Okay, the implementation of 3P, leverage those principles, fitness, movement, forces, those commit and learn, prioritize and simplify. Let those be the foundation to some of your thought process and decision making to then help you to give you a consistent process and eventually create these adaptable plans that we talked about. And then the other cool thing about any injury, and you got to find the silver lining here somewhere, is they're removed from sport. And so there's extra time on their hands. And this often becomes when athletes want to do more. Not necessarily because they want to do more in excess of trying to get back. That may be part of it, but they're also trying to fill their time. Their teammates may be out there, for an hour, 2 hours, and they can no longer practice. Or, they're sitting on the sidelines, but they want to fill the time as well. So it's an opportunity to leverage that enthusiasm or that energy and think just beyond, okay, yes, you have a knee injury, a hip injury, ankle injury, but okay, we have more time today. What about that arm? What about that left shoulder? What about the quality of this move? Let's spend a little bit more time, hammering home the quality of your squat today, right? So you have more time on your hand. So it's a way for us to leverage that and just to again, think beyond the injury and how we can build this, more robust athlete, this more robust human, better than they were before the injury. So a huge thank you guys for tuning in. We're gonna jump right here into the live Q&A, but I want to offer a quick note for y'all, a quick thank you. There's a new performance therapy mentorship coming up. March 2nd is going to get started. Nice 12-week curriculum. You have that for 3 months, and you get direct access to the rest of the content for another 9 months. And so, just by sitting here today, taking time out of your day, time is money ultimately, right? And so, I want to give some of that back to you and offer a 20% discount. So, you'll get a series of emails that'll provide you that insight. But again, just thank you for taking the time today to hear me talk about performance therapy, and I hope you walked away with something meaningful. We got a couple minutes here, save some live Q&A. You can leverage the chat room over here on the right side. Go ahead, type a question that you may have, and happy to answer for you. All right, yeah. Doesn't seem like we're having any questions come through. Not a big deal. Not. I'm glad I'm glad you're all just able to hang out and listen, even if you were, doing other things in the background. Totally cool. So yeah, if you have any other questions, please reach out on social, adam.loiacono, LinkedIn, Instagram. You got the podcast, Finding Small Wins. There's plenty of free resources on my website, adamloiacono.com. Lots and lots of free stuff out there. I'll be offering more of these webinars next month as well. So feel free to tune into the next one coming. And again, thank you for your time today.